milder form. Now, there are still cases of Mpox being caused by clade 2 worldwide, but there are other growing outbreaks at this time of clades 1A and 1B affecting the Democratic Republic of Congo and other countries in Africa. And it has actually spread to other regional countries in Africa that do not endemically have Mpox. And as of August 2024, clade 1B has also been detected beyond Africa. And so we did hear in the news that a case was detected in Sweden, and there are a few other countries that have detected cases. And so understanding in our very global world where there's travel and also the spread of diseases through certain networks, the WHO alerted on August 14th, 2024, that Mpox is a global public health emergency related to this outbreak and has the potential for global spread. So Mpox is not a new virus. It was first isolated in Denmark in the late 1950s, and this was isolated in a colony of lab monkeys. It is a zoonotic infection, and it was first identified as a cause of disease in humans in the 1970s in the Democratic Republic of Congo. And in terms of the geography, it's generally occurring in Central and West Africa. However, there were previous outbreaks of Mpox in the Western Hemisphere. In the United States, an outbreak was described in 2003, and mostly these cases were sporadic, and they were generally related to travel from Africa. However, this changed in May 2022, where a global multi-country outbreak was recognized, and that was associated with person-to-person transmission. It did not involve zoonotic exposure, and many countries were affected. What could be causing this? Well, once upon a time, there was a virus called smallpox that caused quite severe infections, scarring, and disease. It also had a very high mortality. And so the smallpox vaccine was something that was administered quite routinely. But when smallpox was eradicated, that vaccine also no longer was needed. And so there has been an increase in Mpox in the endemic countries, and now we are seeing that it can be spreading to others. So this is a view of the 2022-2023 Mpox outbreak global map. And there were actually over 100,000 cases worldwide. And so this map is from the CDC, and it reports on the confirmed number of cases. So as you can see, the total confirmed number of cases was 99,518. So this is a view, but there were more cases that met the clinical criteria that the lab test may not have been confirmatory or a lab test may not have been sent. And there were cases, as you can see, the large bulk of those cases also occurred in places that did not historically have Mpox. And there were some in cases where it is endemic. And so over 122 countries reported cases. And so you could see this map on the CDC yourself, and then this is actually a map where if you touch the bubbles, then they will tell you how many cases happened and were reported in those countries. The blue dots are the places where Mpox is endemic. And then I just provided just a little brief summary of some places that had cases. In the United States, you will see that there were over 55,000 cases. Oops, sorry. And 60 deaths. And then in the Caribbean region, we also had cases. The Bahamas had 3 cases. We had no deaths. Cuba had 8 cases. The Dominican Republic had 52 cases. Barbados had a case. And so this can spread globally and rapidly. And that was clade 2. Clade 2 did not have a high mortality rate. Now, the WHO did declare an end to the clade 2 public health emergency of international concern in 2023. However, what was noted was that there was a new clade of Mpox emerging in the Democratic Republic of Congo. Thanks to science, the phylogenetics and the strains of these viruses are monitored. And so this was a new strain that was emerging. It started off in those endemic countries, and that transmission was generally community transmission. It did not have an animal link because we know that this can be spread by animals. We'll talk more about that in the other slides, but this was being spread person to person. And so it also spread to neighboring countries such as the Republic of Congo and Central African Republic. And then it spread to other non-endemic countries such as Burundi, Rwanda, and Uganda. And as of August 28th, there were a total of 18 countries reporting having a case, and this includes Sweden, Philippines, Thailand, South Africa, Nigeria, and Pakistan, to name a few. So, how is Mpox transmitted? Excuse me. So, in general, here are the routes of transmission that have been described. Animal to human, and this could be from a bite from an infected animal, body fluids, or preparation of bushmeat. And human to human transmission can occur. And for human to human transmission to occur, it requires direct contact. And that can be contact with the infectious sores, scabs, body fluids, close personal contact with an infected individual, touching infectious material, and then touching the facial and mucous membranes or breaching the skin of the recipient. But what was different in the recent outbreaks 2022 to current is that close contact with infectious material from skin or mucous membranes was occurring. And this was primarily by sexual or close contact as the main risk factor for acquisition outside of Africa. So for those countries, for example, in 2022, the UK was the first country to describe a case. This was primarily being described through sexual networks and close contact through sex. And so here's a study or some information that is available through IHR and reported through PAHO. The cases in the region of the Americas, they were predominantly male, 96% just about. 67.66% of them were men who have sex with men, and 58.8% were HIV positive based upon the data that we have. And so most cases occur from persons who are already symptomatic. They may have a sore or a lesion, but it can also be spread from persons with Mpox, even a few days before they have the traditional rash or symptoms. While they're in the incubation period, 1 to 4 days prior, Mpox can be transmitted from person to person. There are other ways that Mpox can be spread. This can occur through fomites, for example, clothing and linens. So in one particular case report from the United Kingdom, a infection and prevention and control person was cleaning the room where the patient had been housed and maybe had shaken out the linen, and that person did contract Mpox. So it is possible to get it from clothing and linens. What about mother to baby? There have been cases of women who have Mpox. They could have a genital lesion while pregnant, and vertical transmission can occur, but it does not always occur. So in one series of 5 pregnant women with Mpox, one suffered a stillbirth, and the baby did have macular-papular skin lesions suggestive of Mpox. 2 had spontaneous abortions, and one did have a healthy infant. So that did not have Mpox. So vertical transmission can occur, but it does not always occur. There has also been documentation of percutaneous inoculation. So one of the ways that tests are done to see if persons have Mpox, the lesion could be sampled with, say, a scalpel. It could be deroofed, or an aspirate could be done from a pustular lesion. If a needle stick occurs, Mpox can happen. So one healthcare worker did suffer a needle stick and develop a pustular lesion on the tip of the finger where the needle stick happened. So that is a route of transmission. But currently, it's not known if Mpox can spread sexually through semen or vaginal fluid, and that's being studied. So remember Zika virus, we found out that that can be spread sexually through semen, but we don't know if Mpox can be spread through semen, but we do know that close contact, bodily contact through sexual activity is how it is spread. So we're studying if that can happen via body fluids. So as infectious diseases emerge, we learn about them scientifically. So what are we learning? We're learning that clade 1b is rapidly spread through sexual contact, and it's amplified by extended networks. For example, sex workers and their clients, or MSM activity, or multiple partners involved in the sex act. And so the countries outside of Africa are reporting that Mpox is spreading through sexual contact and close contact, especially in high-risk populations. We know that clade 1b is more severe than clade 2 of the 2022 outbreak. However, the mortality for clade 1b is not yet defined yet, but we know the overall mortality of clade 1 from the African outbreaks previously. What is happening in the endemic countries in the Democratic Republic of Congo? This is mainly community spread. And so in the suspected cases, predominantly, it's adults between the ages of 20 to 24 and children less than the age of 5 because of their close contact with adults in the community and the care that's generally needed for children. And then the confirmed cases are generally adults between the ages of 20 to 25 years of age. The incubation period of Mpox is classically 5 to 13 days, but there's a range of 4 to 21 days. And those that have zoonotic exposure may have a shorter incubation period. I'm going to talk now about the clinical presentation of Mpox so that you might have an idea, because there are a lot of differential diagnoses for skin rash. And so hopefully this will help us be able to narrow down who might we suspect as having Mpox, because there, like I said, there are so many other differentials, and we'll talk about some of those, right? So this is typically what has been described for Mpox. So this is in general. There's usually a prodrome. So this is the classical presentation for all the years that we ever knew about this infection in the 1970s. So people will say that they have fever, chills, body pains, back pain, and fatigue. And this is called a prodrome. And this happens before the rash presents classically. And this is when persons are viremic. So they'll feel like they have a very, very bad flu, muscle aches, and so on. There could be generalized swelling of lymph nodes, but it's not always there. And then that's followed by a characteristic rash. And then there can be regional lymph nodes. But this was different in 2022. So like I said, last time in 2022, when this was first emerging, we only had that information from what we classically knew about Mpox. But this was very different. So let's pay a bit of attention to this now. So in 2022, sometimes the lesions presented without the prodrome. About 50 to 70% of people had fever. 25 to 80% of people had body ache. And 25 to 50% of people had headache. But it didn't always necessarily happen that they had the prodrome before they saw the rash. And usually the skin eruption will occur maybe 3 to 4 days after the onset of systemic symptoms, and that will happen for 2 to 3 weeks. And so what does it look like? If you've ever seen chickenpox, it's a papule or a pustule, and it's well circumscribed, it's deep-seated, and it has a little dot on top. It's umbilicated, and they can be about 0.5 millimeter. Now, usually in traditional Mpox, that progressed away from the trunk. It was the face, the arms, the hands, and the legs in traditional Mpox. I have pictures. Don't worry, I do have pictures. And then as this progressed, it crust over and the crusts dry and they fall off just like chickenpox. And they can be in various stages, or they may all coalesce and be in the same stage. And they're described as very painful. And then when they're crusting, they become itchy. And then traditionally, there could be a few lesions, but it also could be thousands of lesions. Okay, but this was a little different in the 2022 outbreak, okay? But there could be less lesions in the 2022 outbreak, that was noted. And then it could also be, it could look like an STI. It could look like an ulcer on the shaft of the penis, in the genital area, in the anogenital area, orally or periorally. And so here's some pictures. A picture tells 1,000 words, right? So traditionally, this is what these pox lesions look like. See, so it's well circumscribed. I don't know if you can see my pointer. I hope so. It's pustular. It has pus inside. They can become necrotic. And there are quite a few of them. They're on the hands of this patient. But this was different. In 2022, what was puzzling is that some of these lesions that they were not disseminated widely. And so here is some information from the CDC. And this is what the lesions are described as. And there could be only a few. So they're firm, rubbery, they're well circumscribed. You can see that it's well circumscribed. Yes. And umbilicated. See the little dot here on top? It's like an umbilicus. And it can occur only in the genital area or anorectal area of the skin. In the 2022 outbreak and this current outbreak, it may not always be disseminated across sites on the body. It could be confined to a few lesions or only a single lesion, and it's not always on the palms and the soles. Another thing is the patient can have rectal symptoms. So understanding how this is transmitted and through sexual networks in certain at-risk populations, like anal penetration, there were cases where the patient only had rectal symptoms, such as purulent or bloody stools, rectal pain, or rectal bleeding. And that has been reported. And the lesions are painful. Like I said, when they're crusting, they become itchy. And the prodrome may be there, but it may not be there. And then it can progress. The presentation can progress to respiratory symptoms, neurological symptoms like an encephalitis, ocular symptoms like a conjunctivitis, for example, has all been described. Now, as I said to you in case reports from the IHR from multiple countries, what was reported that more than 50% of the patients were immunocompromised through HIV. And so we learned that in patients with advanced HIV, the disease mpox may be more severe, and the lesions could become necrotic, especially in those with advanced disease with very low CD4 counts below 100. And this is what this particular study showed, that there were 382 patients from 19 countries with advanced disease in mpox. And this is what the lesions might look like. They could look like widespread, large necrotic skin lesions. And 28% of those patients required hospitalization for the severity of the infection. They could also have nodular lung lesions that's shown on the CT in the upper right-hand side of the slides. There were superimposed bacterial infections like pneumonias, ocular complications. The lesions got infected with bacteria, and death occurred in some with advanced disease. As a matter of fact, up to 27 of those patients died. And then for infectious diseases providers, we want to know about infections that may cause immune reconstitution inflammatory syndrome, also known as IRIS, when we start antiretroviral therapy. And certainly not all infections are our concern in terms of causing IRIS. There are some infections where one can start ARVs without a concern of IRIS. For those of you that don't know what IRIS is it is a clinical presentation of fever, worsening of clinical presentation of certain infections and diseases. That happens when antiretroviral therapy is introduced, and people with HIV, especially advanced HIV, when they start their antiretroviral therapy, especially if there is a current infection happening. And even if you've started to treat out that infection, even dead organism can cause this inflammatory reaction. It really is an inflammatory reaction. And in some cases, it can result in death. For example, cryptococcal meningitis, IRIS is particularly bad. PCP, if ARVs are not started in the correct timing, just the inflammation alone can worsen the patient's status and cause death. And so in the case of mpox, IRIS happened in 25% of those patients, and 25% of those then died. And so IRIS is a concern for people with advanced HIV and Mpox that are hospitalized. So we will need to know about the timing of starting antiretroviral therapy. Those are some of the presentations in general that I touched on. And so lab findings in general, Dr. Edwards is going to talk all about the diagnosis of Mpox, but in general, one may see abnormal aminotransferases, leukocytosis, thrombocytopenia, and hypoalbuminemia. And so clinical features may help in making the diagnosis. However, there are case definitions. I think maybe I'll just touch on the case definitions and then turn over to Dr. Edwards, who will tell you more about how to cinch the diagnosis, get a confirmatory diagnosis, and what do you do, of course, because you may have patients who you suspect Mpox in. How will you take the sample? How do you inform persons? Who do you call? What do you do with the sample, and so on, right? And so let's talk about this. I think what I'll do, I'll first of all skip a few slides. And so it's important to know what the differential for Mpox is, because identifying Mpox can be difficult. And in 2022, because it presented so non-traditionally, it was confusing. It was not straightforward, especially in those patients that had single genital ulcerative presentations. And so it's important to note that these are things that may be important to distinguish from Mpox, chickenpox. It could look exactly the same. Pustular lesions, it can be in different phases and well circumscribed. Measles, bacterial skin tigo can look like this. If someone has a lot of mosquito bites, if they get a superficial staph infection, it can look like this. Scabies and scratching, especially, that can get a superficial bacterial infection. It can look like this. And certainly ulcerative genital diseases can look like this, like syphilis and the chancre. Herpes, again, it can be vesicular, a cluster of lesions, other sexually transmitted infections, and medication-associated allergies. And certainly this is not the only differential, right? So how do we sort all of this out? So it's in the epidemiology. That's how it is for a lot of infectious diseases. For example, TB with persons with chronic cough. What is their risk for TB? How highly likely is this? What is the epidemiological risk that this person has Mpox? So that's something that you really have to considerably weigh. All right. So has the person had contact with a probable or confirmed Mpox case in the 21 days before the onset of their signs and symptoms? That's probably a very, very important thing, because as you go about your clinical practice, you are going to see people with scabies. They could get a medication allergy. They could have chickenpox. They could have an STI. So you have to say to yourself, what is the epidemiological risk here? The link. Is there a link? Has this person had a probable contact with Mpox? Well, how would I know that? Have they traveled to an endemic country? Are they a high-risk population? Had they had unprotected sex with someone who has general pustular lesions now or is confirmed with Mpox? You follow me? So it'll help you to know, no, this person has scabies, for example. And so you will want to know about that. And I can't overstate that enough. What's the epidemiological link before the onset of the prodrome, which may not be there? And so, or does the patient have an unexplained acute skin rash, mucosal lesions, or lymphadenopathy? Or is it in the genital area? And what is the epidemiological link? And then this bottom part, it's at the bottom, but it's very important. And is there nothing else that can explain this clinical picture? It's very important. Is it shingles? Because they had shingles before and they're over 60 and it's painful and they didn't get Zostavax. Or is it measles? Is it a kid that went to a place that has a measles outbreak and was not vaccinated? Or is it herpes simplex? Do they have a risk of herpes simplex? Have they had itchy, tingling in the area, had a lot of mosquito bites or scabies? They have chancroid, etc. And so those are things that you may want to know. And by the way, you don't have to rule out these other things. All right. So on the other hand, if you have someone who's traveled, who has been to an orgy with multiple sex partners or a other gathering, and they are now presenting with a contact and having prodrome, and you really suspect this, you do not then have to rule out varicella and so on before you say, okay, might this be Mpox? But it does take a lot of clinical decision making and clinical acumen. That's a suspected case. So a probable case has the prodrome and the skin rash that we've described, or it could be a mucosal lesion, which is single or multiple oral, as we've described in detail. And they have one or more of, they do have an epidemiological link to a probable or confirmed case in the 21 days before, or they have had a history of multiple or casual sex partners in the 21 days before the symptom onset. Or they may have a positive screening test. Dr. Edwards is going to talk about that. And then a confirmed case is lab confirmed by detection of the viral DNA. And a discarded case is someone that does not have a positive PCR. All right, so now I will turn over to Dr. Edwards to talk more about the diagnosis of Mpox, and I will stop sharing my slides, and then we'll come back together to talk about treatment and a few other things. All right, so let me stop share. Over to you, Dr. Edwards.
Hi, good morning. Can you confirm for me if you can hear me and if you can see my slides, please? Hello?
I'm seeing them, Dr. Edwards.
Are you hearing me?
Yes, and I'm hearing you too.
Thank you. All right. Good morning, everyone. Thank you very much for the opportunity to provide a little bit more insight on the diagnosis and confirmatory diagnosis of Mpox. Okay. All right. So for my presentation, I just wanted to really go over specifics related to how we make the diagnosis of Mpox. Are you still seeing the slides?
Yeah, we're seeing them really well, but we're seeing them not in presenter view.
Okay.
We're seeing the.
I think it should be up now.
Yeah, perfect.
Okay, great. So I wanted to just go through a little bit more about specifically what we are going to be doing in terms of diagnosing patients with Mpox in the laboratory from the perspective of the PHA. But I'll just give you a little bit more insight on what the clinics and private physicians can do as well in terms of getting samples to the National Reference Lab for testing. So as Dr. Forbes presented very well earlier, we know that this virus is an orthopox virus that belongs to the Poxviridae family. And I want to give you a little bit more insight about the specifics related to the viral structure. So we know that this virus is a double-stranded DNA virus, and it's actually larger than the other viruses. So it is very easily antigenic, and it can induce the immune response very well. However, it has the ability to produce immune modulators. And so even though it can stimulate an immune response, it has a very effective way of evading the immune system and allowing that progression of the disease process to occur very efficiently. The virus is a brick-shaped virus with a dumbbell-shaped core, and it is enveloped, as Dr. Forbes mentioned earlier, which makes it more vulnerable to the environmental stressors such as dehydration and desiccants and detergents. And so it's very viable. And therefore, we need to get specimens to the laboratory as quickly as possible to be able to preserve the integrity of the virus, to be able to detect when samples are present for the virus. In terms of its replication and infectivity, the virus enters a cell via yet unknown receptor mechanism. But when that fusion occurs between the cell, the host cell, and the virus, viral content enters the cell and replication occurs within the cytoplasm. The virus is very large, and so it will not enter the host or human DNA, but it replicates very efficiently in the cytoplasm. So let's talk a little bit more about the laboratory confirmation. Obviously, we know that, as Dr. Force had mentioned, there are very specific features that might not necessarily be easily distinguished from other rash syndromes. But we do know that having a very good understanding about the clinical and epidemiological risk can assist us in making the diagnosis. So once you have a suspected case or a probable case, we want to make sure that we collect the specimens very quickly and we take them down to the laboratory very quickly. In addition to that, the specific test that is currently used as a recommended standard or gold standard is the real-time RT-PCR or a NAT. Because of this widespread current multi-country impact and patients meeting specific criteria, we want to establish the best test possible. And so we'll go into a little bit more detail about exactly what test specimens and the kits that can be used to detect the presence of the Mpox virus. I'd like to make a note here that laboratory confirmation cannot be done at this time using an antigen test or our traditional serological test because of the lack of specificity and sensitivity associated with them. So our gold standard and test requirement would be the real-time PCR. Thankfully, the Bahamas does have the ability at the National Reference Lab to do this confirmatory reference lab test. And so our samples, along with the national samples, should be sent to the National Reference Lab for confirmation of diagnosis of Mpox. So when we're about to collect a sample, we always want to make sure that safety is a priority. Our safety as clinicians to collect the samples in the most safe and effective way. So I just want to reiterate the importance of appropriate donning of our PPEs to ensure that we are protected as clinicians and practitioners handling the patients who are suspected of having monkeypox. So we always want to wear a fluid-resistant gown as well as our mask. That mask might be an N95 mask, or it can be a surgical mask, an appropriate face covering, a face shield or goggles, as well as the gloves in that order. PAHO does recommend additionally covering the head and shoes. It's also very important, and I cannot stress it enough, the importance of hand hygiene, both prior to encountering or having contact with the patient, as well as after contact with the patient. Again, when we are finished having contact with a patient, it's also very important to protect ourselves by taking off the PPE appropriately. So whenever taking off the gown and gloves, you should lean forward, move the gown off, and roll away from your body, and the appropriate head and shoe covering should be followed. Thereafter, the face shield and mask should be removed, and then again, appropriate hand hygiene. So the recommended specimen types for collecting a sample that is from a patient that is suspected of monkeypox, as we had seen in the very graphic images, there are many patients that will present with a myriad of lesions, either very few or a large volume of them. But those lesions are very important because they have the highest volume or concentration of viral content available. As we know that infection can occur with direct inoculation or contact with mucosal membranes. And so the virus can be found commonly in the oral pharynx, the nasal pharynx, as well as skin. And so the highest concentration of the virus would be in the skin lesions primarily. And so the CDC and PAHO recommend selecting specimens from the skin lesions as a primary or preferred specimen type. And we have lesions that are actually papular or pustular nature that we can use as a primary source. We can also take lesions from the roofs of these lesions, samples from the roofs of these lesions, as well as lesion crusts. We also want to make sure that we're using the right specimen kit. It's important to note that the sample should be collected using a synthetic material, either Dacron or polyester flock swab, that can be placed in the viral transport medium, or it can be a dry swab. Now, it should not be a cotton-based swab because the natural content of the cotton can inhibit the virus. And so it should never be a natural-based material, either the cotton swab or even a wooden stick swab, because of the potential for inhibiting the virus. Once a sample is collected, we want to make sure that it's stored very quickly in the right temperature, because again, this is an envelope virus and it is very labile. So we want to make sure that the sample is brought down to the laboratory as quickly as possible, and we will store it in our refrigerator until necessary. An additional sample may be collected, and this is primarily the oropharyngeal swab. We also use the same type of material, that is the Dacron or polyester flock swab or dry swab, and it should be sent down in the same time within an hour of collection. As I mentioned, this is an additional sample type. Now, there are other samples that can be used and are being investigated, including whole blood and serum for serological tests, but these will primarily be for research, or if there is a patient who may have had a previous infection, we can see that this is a recent exposure or infection, but not necessarily for an acute diagnosis. Additional samples may also be considered, and they're working on looking at the benefit of doing so. So we would look at possibly including urine, rectal swabs, vaginal swabs in the future. But for the moment, our primary specimen type should be our skin lesion swabs. So I wanted to make sure that we were quite clear on which specimen kit for collection is used. And you might be very familiar with this swab, which is often used for our bacterial infections. So we can use those for patients who are suspected of having a bacterial infection, like for a wound. However, this should not be used for our test of patients with suspected monkeypox, unless there's a suspected superimposed bacterial infection in addition to that for monkeypox. So this is our typical collection device, which is our viral transport medium. And as I mentioned, there are two swabs that can be used. Ideally, when collecting the sample, the preferred lesion type, of course, is the vesicle or the pustule. And you should examine the patient's skin thoroughly to identify which lesions will be tested. You should clean the area with sterile water or phosphate buffer solution and allow it to dry. Then, using the synthetic swab, you can vigorously swab the area, and that should allow for enough DNA from the virus to get onto the swab that can be then placed into the viral transport media. We ideally like to look for two specific areas or two swabs, two lesions that can be used to sample, and both of those swabs can be placed in one single viral transport media tube. Once we've collected the sample, the swab should be labeled appropriately on the tube with the name, the record number, and the sites of collection, as well as a date of collection. Additionally, if the oropharyngeal sample is collected, we want to make sure that the patient is sitting comfortably, that we use a tongue depressor, and that swab is going to be rubbed against the oropharynx and the tonsillar pharynx. Again, the swab should be placed in the viral transport media tube, and the patient's tube should be labeled appropriately. So making the request is quite accessible and easy in ICE now. We do ask that you go to the ICE once you register the patient or selected the patient's name in ICE. You can go to the tab for National Reference Lab, as is seen here, and you can select the specific specimen that is being submitted. Again, if the patient has multiple lesions or has a lesion, you can submit a lesion from a swab of the lesion, as well as other sample types. If you're going to collect crusted lesion or a roof from the lesion, that sample should be sent in another container or another viral transport media tube. And finally, the oropharyngeal swab should be sent in another swab, in another tube. And each of the samples that are being submitted should be ticked off in the requisition in ICE. In addition to that, the ICE requisition, the Mpox diagnosis is a reportable disease at a national level. And so we are asked to submit a surveillance report for every patient that has a possible Mpox diagnosis or suspected case. So we have to include the demographic information for the patient, as well as the name of the physician requesting and a telephone contact in the event that we need to get clarification or additional information about the patient, or if there's a question related to the sample collection. We also want to include the date of collection on the specimen, as well as on the form and the sample types that are being submitted. We also have a responsibility in the process of identifying and testing a patient with Mpox to identify specific key persons in the hospital. So the medical chief of staff, the hospital administrator, the infectious disease consultant, the infectious disease nurse, if the patient is in the hospital, the head of medicine and the laboratory should be informed about the patient. Now, specimen transport and laboratory safety, again, is very important. We need to get the sample to the laboratory within a very short space of time after collection. So we recommend that the specimen be walked down in a secondary container to the laboratory. And that secondary container could be a hazard bag. And once the sample is brought down to the laboratory staff will then handle the specimen thereafter. We are asking that the specimens not be sent down in the chute, but be walked down and given to laboratory personnel. We want to be informed of the specimen to be received so that the appropriate next steps and storage and processing can be made as quickly as possible for the specimen. We recommend that for our laboratory staff that they maintain the level of PPEs that are required to ensure that they're kept for themselves as safe as possible during the processing and handling of the specimen. Now, there is a national algorithm for laboratory testing, and this is followed based on the recommendations from PAHO. So for suspected cases, again, we will have to swab lesions, crusts, or vesicular fluid. The monkeypox virus real-time PCR assay is used at the National Reference Lab. If a patient is recognized or found to be negative, then we ruled out monkeypox for this patient. However, if a patient is positive, the confirmed report will be going to the Ministry of Health for national reporting. We will not be able to officially confirm the clade directly, but based on the assay that is available, we can identify possible clade 1 as well as possible clade 2. So if our test comes back as either negative for 1 or 2, then we have a suspected clade 1b viral strain, and we recommend additional testing or sequencing thereafter. I wanted to make mention of the biological risk assessment because in addition to having labs sent down to the laboratory, we might have patients who are going to the blood bank. And so it is recommended by the Association for the Advancement of Blood and Biotherapies, the AABB, that at this time we increase the specific questions related to blood bank collection. However, these standard questions should guide, but would not be outside of what is expected in terms of our regular assessments for patients with who are coming to donate blood. If a patient has a suspected contact or exposure, it is recommended that these patients will not have blood drawn during that acute period of exposure and will be deferred for 21 days until from the point of last contact. Patients who have obvious or documented exposures or infection will not be allowed to donate blood until there's complete re-epithelialization of those wounds. To date, there are no documented cases of transmission through blood transfusion. For those persons who are working with the deceased, including those who have to transport bodies to the morgue as well as morgue staff, we recommend also that the PPEs that are expected to be worn are maintained in the most appropriate and accurate way to reduce exposure that these persons may also have to patients who are positive for Mpox and who have died as a result or with Mpox. It is also recommended that for morgue staff that postmortems, if are required, will be done with minimum invasive procedures and contact to reduce the level of exposure that they may also have to the virus. I'd like to thank you again for the opportunity, and I hope that if there are any questions, I'll be able to answer them at the end of the presentation. Thank you very much. Dr. Ford, I'll hand it back over to you.
Thank you, Dr. Edwards. Okay, so I hope that you are seeing where I left off before Dr. Edwards covered how to diagnose and how to send the sample down so well. And so let's talk now about patient management. The majority of Mpox patients will have mild disease and recover without medical intervention. And the cornerstone of management of these patients largely is supportive and symptomatic care. And that is rehydration, antipyretics, analgesics, and in some cases, for those with severe disease, they may require hospital admission. There are antivirals, and they are indicated for those with severe disease. And here are some persons that may be at risk for severe disease, including the immunocompromised, pregnant patients, breastfeeding, people who have advanced HIV, those that are having complications, for example, secondary bacterial infections, pneumonias, atypical sites like neurological involvement. And there are several antivirals. Tecovirimat is the treatment of choice, and that has both oral and IV preparations. Viravir, which we have used for other viral infections. And what does the prognosis look like? It is mostly self-limiting, lasting 2 to 4 weeks. And there were few hospitalizations reported during the global multi-country outbreak. In a lot of cases, the patients were admitted mainly for the purpose of isolation. We did not do that here in the Bahamas. So some of the cases were able to isolate at home. And also, they may have been admitted for pain management and treating secondary bacterial infections. And so what do we know about mortality? Generally, clade 1b in the 2003 Democratic Republic of Congo outbreak, the mortality was 4% overall, but it's higher in extremes of age, especially up to 11% in children under the age of 5. And earlier studies put clade 1 infections with having a fatality rate of up to 10%. But this is different now. This outbreak is different now. So we don't know what this current outbreak will look like in terms of the clade 1b mortality. And clade 2 is milder, and the mortality was less than 0.1% in West Africa. And it was generally in immunocompromised persons. Well, how do we prevent it? There is good IPC measures, hand hygiene. If you have a pustular lesion, if the person has monkeypox, they can isolate at home, for example. Healthcare workers can and should wear appropriate PPE, which is the full PPE, including goggles and an N95 mask for seeing the patients and especially sampling the lesions. And there are vaccinations. So let's stop and talk about vaccinations. Vaccinations for Mpox are available in country through the public health system. And they are recommended for people at high risk of getting monkeypox, especially during an outbreak. And there's before exposure. And those groups at high risk may include health and care workers at high risk. For example, persons in the lab that may be charged with the sample, infectious disease doctors and the first line doctors. That is a reason why you may be eligible to get the Mpox vaccine. People who are in the same household or close community as someone with Mpox, including children, people who have multiple sex partners, including men who have sex with men, and sex workers of any gender and their clients are in the recommended group currently for who would benefit from the Mpox vaccine and who's recommended to have the Mpox vaccine based on the WHO. Now, what about after exposure to a known monkeypox case? So this vaccine can be administered post-exposure, and the vaccine can be given less than 4 days with that person, but it can be given up to 14 days after contact if the person is not developing symptoms, i.e. if the if the contact of the person is not developing symptoms. And previous smallpox immunization may help, may have a significant protective effect, but we are finding that it is possible to develop mpox even if persons have had a previous smallpox immunization. But traditionally, and what has been described is that for persons who develop mpox with a previous history of smallpox immunization, the disease course is milder. And how did we find that out? We found that out in the global outbreak in 2022, 2023. There were exposures in some European countries. The people had had smallpox vaccine before, but they did develop a milder form of mpox. And so after an exposure, a person should be monitored for 21 days. And then we talked a bit about infection prevention and control. The person can be home isolated. They should stay at home until the rash is fully resolved and the scabs have fallen off and re-epithelialized. And in the healthcare settings, the patient is placed in a single patient room. The door is closed. A dedicated bathroom in the room is best. And the PPE level, we talked about airborne. And this should happen until all the lesions have crusted over, the crust have separated, and healthy skin is underneath. So we are approaching the end of our time together, our hour together. So in summary, mpox, previously known as monkeypox, it's a viral illness caused by the monkeypox virus. There are two clades, clade 1 and clade 2 with subclades. We have had a global multi-country outbreak of mpox in 2022-2023. That was declared a public health emergency of international concern. That was declared over in 2023. However, mpox continues to be a threat today, and there is an upsurge of cases currently in the DRC and neighboring countries caused by clades 1A and 1B, and this has spread to other non-endemic countries. There are vaccines for mpox. We've talked about the common symptoms and skin rash, and that treatment is supportive. And we are charged to raise awareness about this infection right now because a public health emergency of international concern has been declared because of the outbreak, clade 1B, that is starting to emerge. And so we are charged to be aware and take precautionary measures, hopefully to prevent the global spread and to be prepared should we see cases in country. Thank you very much for attending, and I will turn it back over to Dr. Wallace-Bain to moderate any questions you might have. Thank you.
Thank you so much, Dr. Forbes and Dr. Edwards.
Most welcome.
It has indeed been informative, stimulating, educational experience going through this topic with you. And before you finish, the chat had already started buzzing with questions, and let's get to some of them. Good morning. Excellent presentation. Question. What came first, the monkeypox or the chickenpox? Does monkeypox get as bad as gross scabies sarcops? Is this the next pandemic?
Thank you very much. Chickenpox is older. They say chickenpox has been around since the age of the dinosaurs. So monkeypox, it primarily affected monkeys. In the 1950s, there were some monkeys in a lab that had symptoms, and the virus was first identified. Given the contact that people have with animal species sometimes, this did spread to people. But traditionally, it was through hunting monkeys, bushmeat, or a bite from an animal. But it has since changed. It is possible that could be transmitted person to person, as we see. And then we see that modes of transmission of viruses also change based upon human behavior. And so primarily now, this current outbreak is person to person. And outside of Africa, like I said, it's primarily close sexual contact. Monkeypox can get very severe, or mpox can get very severe, especially in immunocompromised patients. Is this the next pandemic? Well, not just yet, right? But this is why organizations like the WHO, when we monitor emerging infections, the potential for this to spread widely globally has been called. That's why it's a public health emergency of international concern. And when that happens, it's not just a nomenclature thing. That means that countries there are things that we're all called to do for prevention, for readiness, to try and reduce cases. And so we're not there yet, but we'll see how well we respond.
Okay, thank you very much. We had follow-up questions from our Hannah. Well, she made a comment, Dr. Edwards, this is great information. Is monkeypox derived from chickenpox and COVID-19 strains? Was this man-made in the laboratory and accidentally released? Why did monkeypox release in Africa? I think Dr. Forbes addressed some of those. If you care to further address, Dr. Forbes.
It's a completely different virus, and we do monitor viruses closely. We do, even the strains of monkeypox, as you can see, that we are monitoring them, and thank God for science and being able to say that these viruses are interrelated. And that's how we knew that in 2022 that strain of the monkeypox that originated in the UK, where exactly that came from. So they're distinct viruses, they're absolutely distinct viruses. And they did not come from one another. It was not created in the lab. It was like similar to HIV. It was in monkeys first, but then with the interface with humans and animals and their environment, this is how zoonoses can happen, that it can spread from one species to another species. And so that is how monkeypox happens.
Okay, thank you. We have additional commentary. Great job, Dr. Edwards, valuable information. Is this test available in the country? And that was answered in the chat. Yes, it is available at the National Reference Lab, where the turnaround time is approximately 24 to 48 hours. Another question, how long can this be transmissible without treatment?
So someone with Mpox, they can transmit this up to 4 days before they have any symptoms. That's been described in the European experience. And they will be considered infectious until all the lesions have crusted over, the crusts have fallen off, and normal skin is in place. So it depends. And the duration of the illness is about, say, 2 to 4 weeks, usually with the symptoms. So it really depends on the severity of the presentation, right? So that may give you some ideas. But how do we know when we can go to standard infection prevention and control? When the crusts have fallen off and normal skin is in place.
Thank you. We have another question asking if all 3 of the cases in the Bahamas were imported, or 1 imported and 2 local spread.
I believe all of those were imported and had a high epidemiological risk.
Thank you. Okay, we have additional comments. Good morning, all. Thank you for this excellent presentation. Coming in from Esther Mortimer, excellent presentation from both Dr. Forbes and Dr. Edwards. Thank you for an excellent presentation, Dr. Forbes and Dr. Edwards. Much appreciated. Excellent and quite enlightening presentation. Thank you very much. Excellent presentation. Excellent presentation. Is there a way to get samples done for suspected cases in the private sector without going through PMH?
Dr. Edwards, can you speak to that?
Hi, so thank you for that question. I should have mentioned it, so my apologies. The private sector is asked, as well as the clinics, to provide the surveillance information and contact the surveillance department. Those specimens that are collected from patients in the private sector or the clinics are asked to send them directly to the National Reference Lab. What I should have shown was the specifics related to the packing of the samples I did give reference to the requisition form or the surveillance form that's needed. But for the packing, as I've mentioned, we want to make sure that the specimens are kept at a temperature that will help to preserve the integrity. So ice packs would be recommended to put into the container that the box is going to be packaged with. So we will be able to send the viral transport media to in a hazard bag that then should be placed in a harder shelled outer container, and then that can be placed in a box or a cooler to be sent to the National Reference Lab. But the ice pack is very important, and also it's important to contact the National Reference Lab before sending the specimen so they too can be aware of the specimen to be sent in. Thank you.
Thank you for that, Dr. Edwards. Excellent presentation, Dr. Forbes and Edwards. Excellent and informative presentation. Thank you. And we have a question. Are you able to tell us the number of cases globally as well as the death rate globally?
Okay, so I can tell you what's been reported because the outbreak is ongoing, of course, but as of September 1st, there have been 102,977 confirmed cases. Remember, that's an underestimate. And the deaths are 219. Now, the death rate, clade 1B, where we have to see, we're learning because this is a new sort of outbreak, right? But look, we will see what that is. So traditionally it was about 4%. And it can be different with extremes of age, but we are learning. We don't know what the current death rate will be. We'll have that information as things progress.
Okay, we have another question. What is the protocol for private physicians for testing? Out of the 3 cases in the Bahamas in 2022, where did the patients first present?
Generally, these patients are going to present in primary care offices first, almost always with a rash or even something that looks like an ulcerative genital rash, right? And so the protocol, Dr. Edwards just went over what to do, but I encourage you to reach out to resource persons. For example, the General Surveillance Unit can give you further information. And they have available contacts. In Mpox 2 years ago, there was a epi alert that was sent out with numbers, and I'm certain we will be seeing that again in terms of what to do if you have a suspected case, and you can reach out to us. We work as a team, and we'll be able to advise you on how to take the samples and where to send them and how you can do that in the private sector.
Okay, thank you. Are the vaccines available in the country?
Yes, they're available through the Department of Public Health.
Yeah. Will the protocol for access to the kits and surveillance forms be available at the laboratory window at PMH like it was for COVID-19?
Hi, of course, we'll have them available. So if there are questions related to the collection, as well as for the transport, we are there to answer. I'm happy to answer. But the actual forms, the kits will be available and can be collected there at the central accessioning area of the laboratory.
Okay, thank you. Thank you. We have more comments regarding the appreciation for this valuable information that was presented. So as we are well into our presentation time, I would like to take this opportunity to once again thank Dr. Forbes and Dr. Edwards for taking time to present this topic to us. It was most stimulating. It was very informative, and I'm sure that we are all better for having attended this CME session this morning. And I encourage all of you to be on high alert for any cases that we may come into contact with. If you have any additional questions, I am sure that Dr. Forbes and Dr. Edwards would be more than happy to provide the answers for you.
3 o'clock, sure. 4.
So,
Hold on.
so once again, thank you all for attending. I just want to remind you that the second half of our CME sessions for 2024 has officially begun with this session of CME, and we will return to our regularly scheduled CME sessions, which are second Wednesdays and last Friday of each month. That means we have 2 more CMEs for you for this month, next week, as well as the last Friday. So that's September 11th and September 27th. So I look forward to seeing all of you at those CME. Do have a great day.
Thank you very much.
Thank you. Thank you. Good night.